Good morning and welcome to the 9th meeting of the Health and Sport Committee in 2020. I thank all members for your attendance today, including colleagues joining the meeting from remote locations around Scotland. And I thank our parliamentary staff, in particular the Broadcasting Office, for all their hard work in setting up this, the first remote formal meeting of the Health and Sport Committee. The committee recognised the very challenging times in which we live, and we pay tribute to all the organisations, the health and care sectors and essential services for their continued dedicated service and hard work at this time. We do not want to place any undue pressure on these bodies during this public health emergency, but we have agreed, as the First Minister has said, that it is important that public scrutiny, parliamentary scrutiny, and the accountability of the Scottish Government continue. This day is marked every year as International Workers' Memorial Day for those who lose their lives in the course of their employment. This year, the Royal College of Nursing, the Royal College of Midwives and other trade unions have called for a minute's silence across the UK to honour all workers who have lost their lives to coronavirus while seeking to deliver health and care and essential services on behalf of us all. The committee will observe that minute's silence at 11 o'clock. Please can I ask that all participants ensure that mobile phones are on silent and move to agenda item 1 of the meeting. Our first item is an evidence session on COVID-19 and pandemics generally. The committee has agreed to focus our initial attention on 4 aspects of COVID-19, PPE, testing, resilience, emergency planning and preparation, and the impact on care homes. And in order to address these issues, we're starting today with a wider evidence session. We have in mind, of course, what will happen as restrictions are eased and what immediate lessons are already apparent or will become apparent should restrictions subsequently require to be tightened in any way. I welcome to the committee this morning Professor Hugh Pennington, Emeritus Professor of Microbiology at the University of Aberdeen. Hugh Pennington, welcome and thank you for joining us today. Unusually, because of the challenges of managing a virtual meeting such as this, we are going to take questions in a pre-arranged order. I will start with the first questions before asking each member in turn to ask questions and invite Professor Pennington to respond to each member in turn. And once each member's questions have been answered, I will then invite the next questioner and so on until the evidence session is concluded. It's always helpful in these circumstances to keep questions and answers succinct and also to give broadcasting staff a few seconds once you're called in order to operate your microphone before beginning to ask your question or to provide your answer. Let me start. I will begin, if I may, by asking Hugh Pennington on reviewing or in considering the bigger picture around COVID-19 in Scotland. What does he believe, if anything, what more could have been done in advance to prepare the NHS, social care and indeed the country as a whole to tackle such a pandemic? Professor Pennington.
Thank you, Lewis. Clearly we've had a pandemic plan in place, in fact, for many years, but this has been directed against influenza. And of course there are similarities, but there are also big differences between COVID-19 and influenza. So that must be borne in mind when we're talking about the things that were done well and the things that should have been done that weren't done and the things that, well, some things were not done as well as they might have been. Bearing in mind that difference between the two viruses. Now, I declare an interest because I'm coming at this as a virologist who started his career many years ago at St Thomas's Hospital, which I think we've all heard of because the Prime Minister was a patient there, and because I worked with June Almeida, who was the electron microscopist who was born in Glasgow, who actually discovered human coronaviruses in the 1960s. So it was a long time ago. So I do have a little bit of experience of these matters. Now, what have we done well? Once we decided to do something, like, for example, the lockdown, I think that has been successful. But I think what we missed, in a sense, was putting enough emphasis, not in a sense, I'll take that back. what we missed was not putting enough emphasis on testing. Now, I declare an interest here as a microbiologist who used to run a laboratory which main function was testing. So clearly I put that high on my list of agendas to think about, a matter to think about. Now, testing is one of the big differences between this virus, between COVID-19 and influenza. In an influenza pandemic, we do rather little testing. We do testing to find out what the virus was, but most patients never get tested. The test is usually quite laborious and takes a long time to get a result. And basically, with influenza, we have antiviral drugs available. So you treat on spec, as it were, because the antiviral drugs are pretty safe to give. And we also set in motion the development of a vaccine. Now, that usually happens a bit later than the peak of the pandemic, but it means that we can cope with the aftermath of the pandemic and stop the virus going on the rampage again, although we're usually not successful at doing that. Now, we don't have either a vaccine or antiviral drugs available for COVID-19, so prevention is the absolute paramount thing. And the only way we know where the virus is by testing. And we have a very good test. And my main criticism of the UK response, and it's a UK-wide criticism, is that we had a good test available from January the 13th, developed by what happened in Wuhan. The Chinese did a genome sequence of the virus. That gave us information on which one could design an RT-PCR, reverse transcriptase polymerase chain reaction test. And this is a test that's been around for a number of years, and the technique is used in many, many different laboratories. And my main criticism is not that we didn't develop that, we did. The Public Health England developed this test probably within 48 hours of the information coming out. It was put out on the World Health Organization Influenza Exchange website. And so everybody had available the necessary information to develop a test, which is a pretty straightforward exercise if you have the technology available, which Public Health England did at their Colindale lab, a place with which I'm very familiar. And that was developed, and we could have done a lot more to get that test rolling in many, many centres. There was a problem in having a degree of centralisation in that test, which meant we didn't have very many tests available. The number was far too short to do the sort of things we could have done with the test. So that is my main criticism. Not that we didn't have the test, we had the test, but we didn't use all the facilities that were available, not just in public health laboratories or in NHS laboratories, but in research institutes and university departments that do biomedical research. And we know that this is a particular strength, particularly in Scotland. Biomedical research is a particular strength, and there are lots of labs which have the RT-PCR equipment that's necessary to do the test. Not only that, they also have very well qualified, very competent people using this in things like cancer research, not for diagnosing viruses, but for looking at other aspects of nucleic acid biology. We don't need to go into the details there. And these are people who you could be very reliant on as running a very sound, safe test. And I'm sure if they had been asked, they would have put their hands up and said, I'll do it by the middle of yesterday, as it were, because this is obviously a national crisis. So my main criticism rests in the a sort of conscription of all these facilities that are out there, and they're still being conscripted. My understanding is that not all of them are yet in the house, as it were, being used, because I don't know, there's obviously been some sort of delay in getting that sort of conscription act going together. I don't mean conscription in terms of any kind of force. I don't know why there weren't adverts in the newspaper, or anyway, it doesn't matter how that could have been done. I'm sure it could have been done, and I'm sure it could have been done much faster and more effectively. If we go back to the mantra that's been uttered at the number 10 press conferences a bad test, is worse than no test at all. This does not apply, in my opinion, to the RT-PCR test. It is a very good test. It is a very sound test, and it is one that gives you a result within 24 hours.
Thank you very much. The strategy in March certainly appeared to include testing and contact tracing, but we had an announcement from the Chief Medical Officer on the 2nd of April that contact tracing would no longer be used as the strategy had moved from contain to delay. Was that a strategic error? Should, in the circumstances that applied on the 2nd of April, would it have been possible to continue to test and trace? And looking ahead, is there a way to address that issue going forward?
In my opinion, that was a policy error to move away from the idea of contact tracing, because at the end of the day, what we want to do, and I may come back to this later, is to actually get the virus levels down to the point of elimination. If you're looking at what's happening in New Zealand, for example, okay, they had many fewer cases to start with, but they had a pretty draconian approach in terms of stopping the import of viruses. Now they're at a point where they can start talking about, with real sound evidence behind it, virus eradication, not flattening the curve or diminishing the spread or delaying the spread, getting rid of the damn thing altogether, as it were. And I may come back to that later, and I think why, in my opinion, that is a possible thing. But having said that, I don't know why the policy changed from, almost abandoning the contact tracing idea. My suspicion, and this is only a suspicion, I have no evidence in favour of it, but I think it may well have been there just wasn't the testing capacity to do that. So it was the lack of testing capacity that drove the policy, rather than the policy driving the need to get more testing. But that's only a speculation.
Thank you very much. Emma Harper.
Thank you, convener. Good morning, everybody. Good morning, Professor Pennington. Got a couple of questions about personal protective equipment. We know that much has been reported in the media about PPE and whether we have the right amount or how it is delivered to our hospitals across the UK. And I've got a particular interest, as I've been an operating room nurse before an MSP for 30 years, so I've worn PPE every day, and there's been particularly memorable issues when I looked after brain biopsy patients when we were diagnosing for Creutzfeldt-Jakob's disease. And so I'm interested in pandemic planning and whether we have enough PPE anticipated, whether we have the right numbers, who is required to produce the plans or modelling the right number of PPE. Is it a Public Health England thing? Is it a UK government thing? And should we have prepared better and had more PPE? Did we have enough?
Professor Pennington.
Well, I think the straightforward answer is that we haven't had enough PPE, and there's been much evidence produced to that effect, particularly from people who want to use PPE, who either find it very difficult to get access to it or don't know whether they'll have any in 2 days' time, and that kind of thing. And I've even seen pictures on television of people wearing what I would consider to be inappropriate PPE, not sufficiently protective in the environments in which they're working. Whether this applies to staff looking after patients who are COVID positive, I'm less certain. I suspect that they do have the PPE that's required, and that is absolutely vital, because we know from bitter experience, not so much in the UK but worldwide with SARS, that the lack of high quality PPE, the FP3 type masks, was a very bad thing that went wrong in certain places. It went wrong in Canada, for example, and hospital staff got infected because this is another coronavirus, which we may come back to similarities and differences, but certainly that was a big issue with SARS. So that should have been a lesson that should have been learned, that PPE for hospital staff, the people in contact, nursing, particularly people looking after patients on ventilators, because there's a lot of virus being sort of blown out when tubes are changed and so on. It's more the PPE that's available to other people who are meeting patients who might have COVID, who haven't yet been diagnosed. And then there's, of course, the outstanding issue of care homes. So I think overall, we just haven't had enough PPE. We haven't had enough of it in the stores, and even that which has been in the stores, there seems to be a problem in delivering it to places that need it. So that's really, I think, going back to the pandemic plans, which were made, as far as I understand, on a UK basis, and they're refreshed from time to time. And those plans have in them that kind of equipment in terms of having stocks and stores, enough to cope with an outbreak. Now, to be fair to all those involved in pandemic planning, if I could make a suggestion, which is not an excuse for them, but it may be a reason why we just did not pay enough attention to having enough PPE in the stores available to cope with this surge. This is an issue which I may come back to later in other respects, but the surge capacity means that you don't have it for use this week or next week or even next year, but you may suddenly have an event which requires you suddenly to get something in very large amounts, and that's the whole point of having a store of material that's ready in case there's a sudden event, which by definition, these pandemics are unpredictable. You can predict that they will happen, but you don't know when they're going to happen. However, my sort of getting off the hook argument is that we had a pandemic in 2009 of influenza, and the predictions at that time was that the best case scenario for deaths in the UK would be 50,000. But at the end of the day, it was 457. There were some very sad and tragic cases there, but the number of people who had a very hard time and who required hospitalization and who required staff using PPEs was very, very, very much less than what was predicted. And my guess, and this is speculation again, I'm afraid, but my guess is that caused us to put that kind of pandemic planning a little bit lower down on the list in terms of getting orders in for PPE, making sure we had supplies ready for a surge capacity, because the last pandemic was almost a non-event. World Health Organization was criticized for calling it a pandemic. Well, all a pandemic is the worldwide spread of a virus, so they were right to call it that. But people have this idea in their minds that a pandemic is somehow some frightful thing with a high mortality. Not so. A pandemic just means it's the geographical spread of the virus worldwide. However, that apart, I think we're basically, we just didn't have the preparation in there. And then, of course, another matter, which I'll finish on, is where do we buy these things from? And a lot of them come from China, of course. You know, half the world's masks come from China. Well, when China is in lockdown and the factories that are closed that are making these things, well, that's not available to us in order to cope with the problems that we've had because our pandemic planning failed.
Thank you very much. I'll ask Emma Harper to come back in a moment. And I remind both questioners and our witness that time is not infinite, and so please keep questions and answers succinct. Emma Harper.
Yeah, thank you. The issues around PPE is obviously really, really highly important, and we know how important personal protective equipment is, but it comes in different shapes and varieties. And you talked about FFP3 masks, and we know that there's face shields and goggles and different things. But last night, the Panorama TV show was pretty explosive when it talked about PPE, and some PPE was listed as paper towels and hand sanitizer. I think we need to be really clear on what personal protective equipment is, because that way then we can help educate everybody about how important particular PPE is, depending on what part of the areas you work, whether it's intensive care or not. I wondered if you'd have any comments about the importance of PPE and knowing particularly what items are specifically needed for dealing with this coronavirus.
Yes, well, this virus this virus is different from influenza in that we pay rather little attention to PPEs in influenza, except, of course, when patients are very sick, they may be infectious. But one big difference between influenza and COVID-19, I think, is generally speaking, in most of the pandemics that we've experienced in recent times, the mortality has been very low, and it's been focused on particular individuals. I'm sure I'll come back to care homes later, so put that to one side. Care homes apart, influenza goes for rather small and highly specific members of the population, and has not been seen as a particular issue for healthcare staff contracting an infection, which for most people is not trivial, but it's nowhere near severe enough to take you into hospitals. One issue about PPE that's absolutely crucial is having staff trained in their use so that they're using them appropriately. This was an issue in SARS, that I think some of the training in some of the hospitals in Canada was, for example, seen to be defective in the staff just have not been trained in the use of PPEs, but they are crucial in the COVID-19 because, as I come back to saying what I said earlier, we don't have the luxury, it's probably an inappropriate word, but you get my drift, of antiviral drugs that work, like we do with flu, or a vaccine that we can make in quite short order to protect the vulnerable before the pandemic has rolled on too far. We have neither of those. So prevention is absolutely, it's not power, it's the only thing we can do. And the only thing we can do to protect healthcare workers is to have appropriate PPE, and hand sanitizers, in my view, are not PPE at all. PPEs are equipment like gowns and masks and face shields, which protect you when you're in contact with patients, and it protects you from getting the infection, over which once you've got it, there is nothing we can do short of symptomatic treatment.
Thank you very much. Emma Harper.
Okay, thank you. I'll move on to my next questions. It's about social distancing measures that have the most or the least impact on transmission. So what social distancing measures have the best way to reduce transmission of coronavirus?
Professor Pittman.
The evidence coming in that the distance that you keep between individuals is by far the most important aspect of the attempts we're making to control the virus. But, if you keep your 2 meters distance from somebody else, the likelihood of the virus transmitting itself, from somebody who's breathing out the virus and you breathing in the virus from somebody at that distance, it's not zero, but it's very, very low. And clearly, all we can do in this outbreak is to reduce the risk of transmission as far as we can, rather than saying we can prevent it completely. I mean, FP3 masks might do that, but that's a very special circumstance which clearly doesn't apply to the general public. But it's the distance between individuals that's the important thing. And then second to that, what traditionally called foam outs, which is the virus getting onto a surface and then you getting it onto your hand off that surface and touching your face. And there's been a lot of emphasis on, hand washing and all that kind of thing in terms of interrupting that route of transmission. I think the evidence so far is that might be important, but it's very difficult to find any evidence that it actually has occurred for obvious reasons. We're not going around testing door handles and that kind of thing. So it is a fairly straightforward thing to do, is hand washing after you've touched a surface that might have been touched by somebody else. And clearly, what I'm looking forward to, just as an aside, is a reduction in the number of cases of food poisoning. People in washing their hands, that's one of the most important things. But it's for the same reason, that you're touching a surface which may have some bugs on it, and the virus or the bacterium gets onto your hands, and then you touch a piece of food and eat it. It's the same with the virus, except that the virus obviously has to not be ingested by the mouth, but get into your nose and into the back of your throat where it starts growing. So social distancing in terms of distance is by far, in my view, the most important aspect of the control measures that we put in place, followed by simple, straightforward things like hand washing. Soap and water does extremely well. I can quote the evidence in support of that if you want. And so we're really, at the end of the day, looking at those as the important things. I think public gatherings is a separate issue. And of course, public gatherings where everybody is crowded together like in a pub, getting social distancing rolling there is going to be very difficult. But it could well be possible to do it, for example, in a restaurant where the tables are far apart and so on. I think there's an argument to be had about football matches, but we needn't go there at the moment because clearly, if I can just come back to the social distancing, because the virus is on the wind. If we're in Scotland where there's a fair amount of wind, the chance of catching the virus is probably less than it would be, well, certainly on a tube train in London. But, that's common sense, isn't it?
Okay, thank you very much. Miles Briggs.
Convener, and good morning, Professor Pennington. We heard from the First Minister yesterday that she believed the reproduction number of the virus was around about 1 in a community setting. And so from your experience, what do you believe the reproduction number of COVID-19 is currently in a hospital and care home setting?
Professor Pennington.
Yes, thank you very much. It's very difficult to do any kind of quantitation on this, measuring. We have to look at what's happening in these places and then work back from that to say, well, we think that the R number there was less than 1 or greater than 1. If the R number is less than 1, it means that each person will be infecting on average less than 1 individual. And at the end of the day, if that is continued across the piece, the virus will die out because it will run out of people to infect eventually. If it's greater than 1, the virus will continue to spread. And the R number for COVID-19 that's been estimated in many studies, which are then put together, is about 2.7, which is probably what it was at the beginning of the outbreak, once the virus had started rolling here. In care homes at the moment, I would classify care homes at the moment where there has been virus as almost super spreading environment, where the virus is really going on the rampage, because clearly the way care homes are set up, they're set up for social interaction between the residents and of course the staff. The staff have to be close to the residents. Many of the residents will have dementia and so on, which makes it quite difficult. But they've forgotten, because of their illness, they have forgotten about hygiene. I'm not being pejorative here. I'm just, it's a plain fact. These residents of care homes, and we've known this for many, many years, that care homes are places where once you get an infection into a care home, it has a very good chance of spreading far more than in the community at large. So in the community at large, they are maybe less than 1, but in the care home, I don't know how high it is, but it may be as high as 10 or even more than that. Or it may be as high as in the cruise liner, the one off Yokohama, where when that outbreak started, it was 14. And because they tried to control it and took away all the passengers who had symptoms, it fell to about 1.7. It didn't stop transmission, but it reduced it. And that was where patients, individuals, were isolated in cabins, and they were kept apart from each other and so on. In a care home, under the best circumstances, the best run care homes, our number will be much higher, probably higher than 10, and maybe more than that. And that's really based on the number of cases that we get in these care homes. The number of tragedies in care homes, it's reported daily how many people, unfortunately, have died of COVID. And that will be an underestimate of the number of people who've been infected, because we know that this doesn't cause 100% mortality. The mortality even in high-risk groups is much less than that. So the virus is really going on the rampage in care homes. And this is an issue which I hope we come back to, because clearly at the end of the day, the only way we can stop care home problems is to stop the virus getting in there in the first place. Because once it gets in, the virus really does it's out of control.
Okay, thank you. Miles, please.
Thank you for that. There's obviously real concern around the infection rate, both in a hospital and care home setting, but what actions do you think will have to be put in place to manage the higher rates which you've outlined from a hospital and care home acquired COVID situation going forward as we come out of lockdown? And how do you think we can create clean capacity in our NHS to be able to start up some of the vital work and operations around cancer and heart disease?
Professor.
Yes, I think. Yes, thank you. There are two separate issues there. I think one is, if I can go back to the last one first, how to basically make hospitals safe places, so that we don't get the situation which we seem to be in at the moment, where people are trying to go to hospital because they worry about catching the virus there. Well, I think many hospitals are already split their sort of activities into red and green zones, or whatever the colour is, it doesn't matter, but you have a sort of COVID area and you have a non-COVID area. And clearly the public has to be reassured that the non-COVID areas are definitely what the label says, that there is no chance of COVID being in there, so that when you go in for your operation, and obviously there's a backlog now that will have to be sorted out, because a lot of the discretionary operations, the cold operations, as it were, have just been put on hold, and there were quite long waiting lists there already. So that's very bad news for somebody with a bad hip, for example. But they don't want to go into hospital and catch an infection like COVID. And many, of course, of the people who require hip operations will be in high-risk groups, just by virtue of age, for example. So it's down to the hospitals to be absolutely punctilious about making sure that they have these two separate areas whilst the virus is still busy, and communicate that to the public and almost demonstrate it to the public that, yes, this is how it goes. You go in through door A for you had a heart attack or whatever it is, and then you go into door B if you've got symptoms which might be COVID, and so on. What would be even better would be if we could do testing so that we know even before somebody goes into hospital that they're testing positive, not wait till they're in there and then test them when they get in there, because there might then be people who have the virus going in through the non-COVID entry. And what we do know, and this is a very important statistic, is that people are infectious before they develop symptoms. So it's pointless just saying, oh, you don't have a cough, you don't have a fever, you don't have any other symptoms of COVID, therefore you're okay. Far from it. There's good data coming out that suggests that maybe as many as 40% of infections are being transmitted by people before they show any symptoms. And so that's an issue. This is where testing again comes back as a paramount thing, to make it absolutely certain that we're not categorizing people in the wrong category, that we're not missing anybody who's likely to infect other patients in a hospital, for example. I think the other issue was care homes. How do you stop the virus getting into care homes? Well, again, we can only do that by testing. We can only test anybody who goes into a care home on a regular basis, give them a test, make sure that the test is negative before they go in, and keep on testing, because a single test result, if it's negative, doesn't mean to say that you're not incubating the virus, for example. And so this would have to be done on a regular basis, a screening test, and clearly you wouldn't be acting until you got the result. You wouldn't necessarily be self-isolating, but you would just be delaying a little bit. We could have a routine there that all people going into care homes had been tested before they went there, and the test result was negative. And anybody who's going in on a regular basis would have to have repeat tests just to make sure that they hadn't picked up the infection. Because I go back to my point about symptoms are a poor guide to whether somebody has the virus. And a very poor guide as to whether somebody is capable of transmitting the virus. And once you get the virus into a care home, I think to talk about testing once the virus has got in and finding it is too late. That virus now has a very good chance of spreading in the care home and causing mischief, causing a disease over which we have no control because we still don't have any adequate treatment.
Thank you very much. Sandra White.
Thank you very much. It's unmuted. Thank you, convener, and good morning, Professor. If I could just pick up on what you just said there about testing. I'm actually going to talk about care homes or ask your advice and your expert advice on care homes and what you think. Really what you're saying is that the whole of the population would need to be tested because basically we don't know if you've got it or not, or you're a spreader of it. Would lockdown not be a better way of controlling this pandemic? I'm just throwing that in from the last one. But what I do want to ask is regarding care homes. Now, we know guidance was set out by Health Protection Scotland in regards to care homes. If anyone shows any symptoms, then the people in the care home have to phone, the health sector to get advice. And also the guidelines stated about protection. As you mentioned, hand washing, very important, etc., and ensuring that there's good protection there in the care homes also. What I want to throw into the mix in this one is care homes by themselves. It's a very complex area regarding private care homes, local authority care homes, voluntary care homes, not-for-profit care homes. So it's pretty complex. In fact, well over 70% of care homes are privately owned. So I wonder how you see that panning out in regards to advice to care homes and what could or should be done to best protect care home residents. Thank you.
Thank you very much. Professor Pennington.
Yes, thank you. Yes, well, the last thing you said is the absolute paramount thing, is protecting the residents of care homes. And basically, the only way we can protect them is to stop the virus getting into the care home in the first place. And if I can just go back a little bit to talk about my personal experience in this area, not with COVID-19, but I gave evidence at a committee in the World Health Organization in 1997. And we were talking then about care homes as incubators of infection. And the infection was one which unfortunately is still commoner in Scotland than anywhere else in the world, which is E. coli 157. We've had very sad outbreaks in care homes with that particular bacterium. It spreads in a different way, but it's the same issue, that the population there in the care home, as with COVID-19, is very vulnerable to having very, very serious outcomes of infection, and the sort of hygiene there is something that is more difficult to control than in an ordinary domestic environment for obvious reasons. And, as I said earlier, we'd like to encourage the residents to get together and meet together for their food and so on. Goodness gracious, ideal way for spreading infection. So, and we've seen this with influenza, that we've had outbreaks of influenza in care homes with high mortality as well. So this is not a problem that, it's not a new problem. It's an old problem. It's a problem that we've seen before. We've seen tragedies before. And prevention has to be the mantra here. And the only way you can stop it is stop the virus getting into the damn place in the first place, as it were. Sorry about the words, but I feel quite strongly about this. That and the only way we can do that, and if we got a vaccine, clearly, then one would say you can't work in a care home until you've been vaccinated. But we don't have a vaccine. We may never get a vaccine. We may only get a vaccine that's only partially protective, and so on. We can't wait for a vaccine. We have to do something now, because the problem is with us now. The mortality in care homes is, people argue about whether it's 40% or 50%. I mean, these are outrageous figures, by any estimation. And the only way we can do it is by prevention. And coming back to testing for the whole population, well, the more we test, the better. But clearly, this is something that, again, we should be looking at trying to prevent it by stopping the virus getting in, by making sure that nobody going into a care home, of any kind of person going into a care home, should not have the virus and take it in there, because unwittingly, they may spread it. It's not their fault that they've got the virus, probably. It's not their fault that they don't know they've got it. How can you know whether you've got it or not? Particularly as 40%, or roughly speaking, of people who transmit don't have any symptoms. You feel fine, and so you go to work. So there has to be a testing regime which makes sure, as far as it's humanly possible, that the virus is not being carried into their care homes, because this is person-to-person spread.
Thank you very much. Sandra Hart.
Thank you, Professor. You've near enough answered my second question in regards to the approach. We are talking about testing, but it still doesn't protect the people in the care homes, unless, if you know you've got the virus, you have to self-isolate. And people who have the virus and they're in the care homes have been, self-isolating. That's been the guidance that's came in. What I want to ask is, how probable is it to be able to test everyone who are going into a care home, agency nurses, etc.? How probable is it? Because as you said yourself earlier, if you're going to be tested, you may not show any symptoms. So I'm just asking, how probable is it that somebody who tests went into a care home, a contractor, an agency nurse or anyone else, and they don't show the symptoms, but they could be carrying it? And that's my, real concern. How do we stop that?
Thank you very much. Briefly, Professor Pennington.
Well, that's a very good question. First of all, we have to have the testing capacity to test far more people than we're testing at the moment. At the moment, testing is rationed because we don't have enough test kits available to do the testing to the scale that we need to do, in my opinion. And, I know that generally speaking, lab tests often do get rationed, that if somebody comes in with a particular disease and there's a very complicated test for it, you first of all decide whether it's likely that they have the disease before you do an expensive, complicated test. We're not talking about an expensive, complicated test here. In any case, we're talking about a situation where money does not seem to be an object. It doesn't seem to be holding us back. We should be able to, without spending vast sums of money, maybe significant sums of money, to be able to do all the testing we need to do by scaling up the number of machines, the number of people doing it, and so on. And I've been through that already, saying that is feasible. That is feasible if we put our minds to it and have this sort of conscription of all the machines and so on. So testing capacity is the thing we must address first of all, so that we have enough tests available. And then we obviously have to set in place a regime for testing individuals, particularly individuals who are going to come in contact with the vulnerable groups in the population. And we know who they are pretty well, that age for this virus is quite different from influenza in the sense that with COVID-19, the older you are, you're more likely to get a severe, complicated infection, and unfortunately, one that ends in your death. And there's a very clear, straightforward. It's unlike most infections where there's this clear relationship between age and a bad outcome. And so we know that if you're over 60, and if you have all the other conditions that get commoner as you get older as well, like high blood pressure, heart disease, diabetes, and so on, that also adds to the risk. And clearly we know that if you want to look for people like that, with all these comorbidities, underlying health conditions, who are elderly, where's the best place to go and look for them? You'd go and go to a care home. And if you ask the residents, put up your hand if you've got 3 medical conditions, I suspect most of them would put their hands up. And it's just a factor of getting old and all that kind of thing. So these are people who are absolutely at the top of the pyramid of the people who need protection. And I think if we do have to continue rationing testing to prevent the virus getting into care homes has to be right there. Okay, healthcare workers as well, separate issue, but certainly residents in care homes are the most vulnerable in the population by definition. We don't need to do a survey to find out that. We know that they are, and clearly they're the people to focus on in terms of any expanded testing regime as high priority.
Thank you very much. Alex Cole-Hamilton.
Thank you, Convener. Good morning, Professor Pennington. I wonder, before I get into the substantive question that I want to ask, I wonder if I could touch briefly on the likelihood of a vaccine. You said already in this meeting today that we may not get a vaccine, or not an effective one at that. And that would seem at odds at some of this more optimistic projections about vaccine from other public health professionals and virologists who say that the prospects are very good. Could you just tell us why you're slightly more pessimistic, and what are the factors that might prevent a viable vaccine hitting the marketplace, as it were?
Professor Pennington.
Well, thank you very much. If I could answer it in two different ways. First of all, I was hired into microbiology by Professor Ronald Hare, who was one of the first people to develop an influenza vaccine. And he was working in Canada at the time, and he was hired by the US government to produce a flu vaccine. And he was very negative about flu vaccines, because by the time he'd got the vaccine developed, it didn't work. And so maybe that's declaring a kind of skepticism that's there from historical events. The virus didn't, that vaccine didn't work because the virus had changed. It wasn't that the vaccine was no good. It was that the virus had changed, which flu does, of course. And that's why we have to have new flu vaccines pretty well every year. We have to change the components in the vaccine because the virus is mutating all the time and throwing up new variants, not necessarily big ones, but ones big enough to make the vaccine, last year's vaccine, not very good for this year. And of course, we've had recent problems with vaccinating to protect the elderly with flu vaccines, which have been, Ronald Hare did this in the 1930s. And, we have made some progress in flu vaccines, but we're still not there with a vaccine that is anywhere near as good as MMR, for example, in protecting against infections. And many of the vaccines that are being tried for COVID-19 are based on that technology. Now, I'm not saying that, in fact, many of them are not. They're based on other technologies. One type of technology is by injecting the nucleic acid into people. Never been tried, never been shown to work, but it's an experimental approach that might work. I have my doubts about it, and I have molecular biology doubts that if you inject the virus's RNA, it might then recombine with the RNA of the COVID, the coronaviruses, which we all suffer from every year, which cause the common cold. The commonest cold viruses are coronaviruses, which are quite trivial, but still. So that's an issue that I have with that, and that will come out in the wash. I hope it doesn't come out in the wash by people falling ill as a consequence. But I'm skeptical about putting a lot of money on vaccines, in the sense, although there are about 80 different groups developing them, there's no guarantee that any of those groups will come up with a vaccine that is going to be any better than the influenza vaccine. And there is already kind of evidence suggesting that immunity against coronavirus, against COVID-19, is not particularly strong after infection, that many people don't really develop very much in the way of antibodies. They recover from the infection, which might suggest that traditional vaccines are not going to be particularly effective because they will be generating antibodies, which many people don't have much in the way of after an infection. This is actual data which caused the World Health Organization to say these sort of immunity certificates that has been talked about. If you recovered from an infection, you wave this piece of paper and saying, I'm immune, I can now do anything I like without worrying about social distancing, are very misleading because some people haven't really developed much immunity. So I'm going a little bit of length about this to say that I hope that a vaccine will be developed, or that vaccines will be developed that will be effective. I'm not putting any money on it at this stage. I think probably the best thing we can hope for is a vaccine or a set of vaccines which will be partially protective. They may not work as well in the elderly because most vaccines don't. It's a general phenomenon because the elderly's immune systems are, like the rest of them, elderly, don't work too well. And so to put all our money on a vaccine as the way we can sort of end the current crisis, I think would be mistaken. because we may never get to that point, or if we did get to that point, it's not going to be as good as we would like. Apart from the problems about manufacture, we don't in the UK at the moment have a vaccine manufacturing capacity. I think one is being hurried along, although I don't know whether the men working on the site are socially distancing or not. That's another issue. But still, we don't have a vaccine manufacturing capacity, and we've had problems in the past with if we get one made somewhere else, we have to put our order in. And, there are all sorts of practical problems like that, which again mitigate against having a vaccine by Christmas. Highly unlikely.
Okay. Thank you very much. Alice Cole-Hamilton.
Thank you, Convener. Professor Pennington, you are quoted in a recent newspaper by saying, I think what we should be aiming for is not control of the virus in the sense of flattening the curve or preventing a second peak. We should be aiming at the eradication of the virus. That's a clear strategy. But I just wonder if we can talk about the sort of the metrics of that, how you measure when's the point at which we can come out of lockdown and begin to eradicate this via contact tracing. What is the level of infection in the country that you would see as being the tipping point at which we can begin to meaningfully contract test, isolate, and identify any sort of avenues of community transmission? What sort of order of magnitude in terms of new infections would we need to get to before that was possible?
Professor Pennington.
Yes, orders of magnitude. We've got to be at least 10 or 20 or 30. I'm being rather broad because I just don't know what that figure would be, but we have to have a lot less new cases appearing before we can even start thinking about moving to a sort of contact tracing system, because we can't do it with the number of cases we're having at the moment. There are too many cases, and they're occurring across the country. Okay, some parts of the country, the decline seems to be going better than in others. But on the other hand, there is still an enormous amount of virus about being transmitted. And until we get that down by at least one order of magnitude, which is tenfold, I don't think we're really in the game of starting contact tracing. And that's not because there's any kind of link there. It's because we don't have enough testing facility yet to do it. We need a lot more testing facility, and we need a lot fewer cases. Those two combined will then mean it possible to go out and hunt for the cases, just as the New Zealand Prime Minister has been talking about, in the last couple of days. Well, because they're in the fortunate position in New Zealand, having yesterday they had fewer cases than Orkney had, and I think there's a big population difference between the two. But anyway, we've got to have a very substantial decline in the number of actual cases. Now, we may get there in a reasonable time, depending on how well we maintain the current social distancing. The social distancing is more important than the lockdown, in the sense that I think that's affecting the whole population. The lockdown is clearly more focused on particular areas of business and so on, and it's stopping sort of events where people might get infected in a particular setting. It's stopping that. Those are more easily manageable in some ways than the whole spread of the virus just going under the radar as well. But at least an order of magnitude before we can start thinking about doing the contact tracing. I would hope we get to that order of magnitude, that tenfold less number of active cases being reported on a daily basis quite soon. I would hope so, because my timetable, it's also been in the newspapers, is we might be able to see the damn virus off by Christmas if we really put at it. And the reason I say that is, well, the Chinese did it in shorter time than that from their start, where they had a very big outbreak to begin with. They put in obviously very, very draconian control measures, some of which we couldn't do here. But on the other hand, the general approach was the same. It was the social distancing, it was the testing, it was the contact tracing, it was the closing of public events and so on. They put a lot on emphasis on travel because they didn't want the virus to spread out to the rest of China. And they were pretty well successful. There were small outbreaks in Beijing and Shanghai and places like that, but they managed to cope with that. But of course, we would have that added problem in the UK, but we wouldn't be wanting to stop people moving about the country. I don't know whether we could stop people moving about the country going to work, for example. So that's an issue that, if we get down to a very small number of cases and we're doing the contact tracing to hunt the remaining cases, what we would like to be in would be the situation where we're worried about virus, not our own virus, but virus being imported into the country. That would be a very good outcome. And clearly that would depend on what the virus was doing elsewhere. It might still be quite busy in the United States, so we'd have to think about some controls on people arriving from the United States. That's an easily manageable thing if it's relatively small numbers. I wouldn't be worried about that. It's getting that basic number of cases, and the important statistic is the number of new cases which we know are confirmed. These are the hospital admissions with the virus. If we can get those down to tenfold less than we've got now, I think we could start thinking about a very aggressive contact tracing program, which again would require the massive increase in the testing capacity. We put those two together. I think we could think about eradicating the virus in the UK in terms of our own virus moving among our own citizens, and then we could worry about importation when we got to that nice position.
Thank you very much. I'll call Brian Whittle. Can I remind both Brian Whittle and Professor Pennington that we will be pausing in 2 minutes?
Yeah. 5 minutes time. For the health and other people lost their lives as of workers. One population before the members and staff the minutes.
Thank you, convener, and good morning, Professor. I'll make it quick. Okay, I'll make the question quick. I wanted to discuss there's a lot of discussion just now about starting to lift some of the lockdown restrictions and the concern around the potential for a second peak or surge within the virus. So I think, Professor, I'd like to ask firstly, in the absence of a vaccine or treatment, in lifting lockdown restrictions, is there an inevitability around a second peak or surge?
Professor Pennington.
No. I'm not sure where this second peak idea comes from, except, well, I know where it comes from. It comes from flu, because when we have a flu pandemic, we always get a second peak, and sometimes we get a third peak. Now, why we should get one with this virus, I don't quite understand. We actually don't really understand where we get a second peak after flu, despite having antiviral drugs and vaccines and all that kind of thing. It just seems to be a phenomenon with flu. And I don't see any reason myself, and I haven't seen any evidence to support the idea that there would be a second peak of the virus. It's something that I think is a hangover from the flu pandemic planning, and the mathematical modelers have injected in, oh yes, we might get a second peak, or we would get a second peak if we didn't do things properly. I think what we would get rather than a second peak is we'd get the virus dribbling on. Maybe there would be local instances where the virus would take off, and so on. And that's been the pattern with this virus, that there have been outbreaks which have been due to particular social occasions, well, not social, but gatherings of people, like cruise liners, like in South Korea, they had a religious sect which was responsible for a lot of their cases because they all met together, got infected, and then went to different parts of the country, taking the virus with them. But that's not a second peak. A second peak, I think, is something that is basically a flu phenomenon, and there hasn't been one. There hasn't been one in China. They managed to get the virus down. It took a long time to get well, not a long time, but a reasonable length of time to get the virus numbers down. But now that
Attention. All login users are now invited to observe 1 minute to remember all the health care cost their lives to coronavirus at all workers' Memorial Day.
Thank you very much. I will now go back to Brian Whittle and Professor Pennington if there are...
1 minute silence, now complete. Thank you for your...
Thank you, Convener, and thank you, Mr. Pennington.
Brian Whittle.
Can I go on to the next part of that question around antibody testing? And I think you fairly scornful around the potential for antibody testing, and if antibodies are detected, that doesn't necessarily mean there's going to be a level of immunity, or that you're even going to be unlikely to be a carrier. So, given the amount of attention that's been put on antibody testing, what role do you think, if any, antibody testing should have or could have in a potential exit strategy?
Yes, I think, well, my view has always been that the antibody testing is for later. It will tell us what happened in the past, because basically you develop antibodies after you've had an infection. But I don't think it's going to be very helpful in terms of control, because the test that is really important in that is finding out whether you've got the virus now. And the antibody tests clearly had many technical issues in terms of delivering a safe result, safe in the sense of meaning, what it says on the label, that this means that you have been infected with COVID-19. We know that some people don't develop very much away antibodies anyway after an infection, so they might test negative. And we know that there might be cross reactions with other coronaviruses, which are very common in the community. So it may mean that you have a false positive. And I think sorting that out is quite tricky. And as a virologist, if I could go back to, many years of doing virology, we used antibody tests to test retrospectively whether somebody had a respiratory infection. And sometimes we use it to try and find out what the virus was, but usually we did it just to give us a diagnosis in somebody. But it wasn't a diagnosis that was terribly helpful in treatment, because usually by the time the antibody test result, by the time you develop the antibodies, the patient was either better or dead. So, it was something that was very useful in epidemiological terms after the event. So I've always seen antibody testing as something that, yes, we can evaluate what has happened, we can find out where the virus was, but basically, I think to put so much emphasis on it was not quite right. That it was seen as the holy grail, it was seen as the sort of game changer. I don't think it was ever going to be a game changer. But even if those people were right, the fact that we've had so much difficulty in developing one, that means that it's not going to be a game changer. And also, people doing tests at home, well, who's going to collect the information? I mean, it doesn't really help if you have a test that's that's not particularly reliable. You do it at home. What are you going to do with the result? The epidemiologists aren't going to know what your result is. It's going to be a private thing. So, again, never saw that as a particularly valuable thing in terms of any kind of control measures. So antibodies, I think, it's going to be very useful at the end of the day to find out what has actually happened in the past. But actually, in terms of helping now, like, for example, preventing infections in care homes, just not there at all. Just not there at all.
Very much. David Stewart.
Thank you, Convener. Good morning, Professor Pennington. Could public health responses to the virus differ among areas depending on incidence and prevalence?
Professor Pennington.
Oh, absolutely. There's an enormous variation in the incidence of infection across the country. Clearly, London in England has had a very hard time. Birmingham had a hard time, but that developed a bit later than London. Other parts, like down in Cornwall, it's been suggested by Jeremy Hunt, for example, that Cornwall could come out of lockdown earlier because it's had fewer cases. It's had quite a few cases, nevertheless. Now, in Scotland, I think I've gone public on the Northern Isles, particularly Orkney and the Western Isles, as places where we could really do something different from the rest of the country, because they've had so few cases, and they have very good public health systems, and they have controls of incomers in the sense that you can't go there unless you have a very good reason for going there. So they could be useful areas where lockdown could come off earlier, like, for example, opening schools and opening small businesses. It doesn't mean to say it'd be the end of the road in terms of the impact of the virus and control measures, because there wouldn't be any cruise liners welcome there, and there won't be problems with industry, with, well, say, the fishing industry and exporting their fish because of, problems outside the UK in terms of getting to the market. But nevertheless, because they have so few cases, they're a bit like New Zealand in the sense that in fact, I think Orkney's had 3 more cases on record than New Zealand has got at the moment, but nevertheless, tiny numbers. And clearly that could happen, but only if we had a comprehensive testing strategy in those places to make sure that the virus wasn't going under the radar, which would be highly unlikely, but possible. And it would also reassure the residents of those places that, they were in this fortunate position of an area of the country from which the virus had been eradicated. It was no longer present at all. And if they kept up the controls of, the flights to the islands and the ferries, that would be a very reasonable. But you still have to keep the testing going, because you still want to give absolute assurance that suddenly, an individual hadn't got in, unbeknownst to them, carrying the virus, started an outbreak, and bingo, away you go, back to square one. So the testing, again, is absolutely vital for that to be an effective strategy. Now, when looking at other parts of Scotland, I think the Highlands is the next health board that's had the smallest number of cases. And of course, there are special factors there in terms of geographical distribution and where the virus has been busy. Has it been concentrated on Inverness, or, has it been busy in Dingwall or wherever? The information that has been published is very sparse. In fact, it's almost zero in terms of where the virus is within a health board area. And it would be very useful to know that before making any further comment. Has the virus been focused? Has it focused its attention on particular parts of towns? And if that's the case, and I think it's reasonable to expect it might be, those are the areas where you'd really focus your aggressive testing and contact tracing efforts, again, to make sure that the virus that was busy in a particular street or, a particular area, and you could knock it on the head. It's unlikely, I think, although there are staff coming and going, it's unlikely to be getting out of care homes. But again, you'd have to pay a lot of attention to that as well as foci of infection. And this is traditional shoe leather epidemiology, the sort that John Snow practiced in the 1850s in London. And, we haven't done very much, at least there's been very little published on that so far in this particular crisis. And it'd be nice to see more data like that if it's been done.
Professor Penton, rightly we have we've rightly focused on the health implications of the virus and the discussion we've had today, but clearly we've got to look at the economic and social and indeed human rights issues of this, particularly the effects that it's having with social distancing on issues, for example, on mental health. What's your assessment of that, and how do you assess the First Minister's view that in terms of social distancing, it's important to have an easy, simplistic national message when it comes to enforcement?
Mental health is not my area of expertise, but I can see why the control measures will be very distressing for certain people who like to have a lot of contact with other individuals, for example, and need that, to keep them going and so on. And this is obviously a downside to infection prevention, that you're trying to prevent an infection which is potentially lethal. Well, it's actually lethal in some people, and there's more to it than lethality, because we don't actually know how well some people who've had a serious infection are going to recover from it, because it's absolutely evident from all the data that this is not just a question of getting severe pneumonia, that the virus affects other organs. There have been problems with kidney failure, and it may even affect it may have an effect on your brain, and it may certainly have an effect on your nerves and reflexes. There are some people, for example, who have very low oxygen levels in their blood, but they're not breathing in a rapid way and responding because the reflexes that normally do that have been turned off, for example. And then there's this story about loss of smell. So this is a virus that has a broader effect on people than just the pneumonia and needing ventilators and so on. But clearly there are big effects on people's feeling of, their mental health. Let's not be shilly-shally about it. I think equally worrying, of course, is the effect on other aspects of healthcare, that hospitals have shut down their discretionary sort of activities to make room in their ITUs and convert operating theatres into ITUs and all that kind of thing, which is obviously going to have an effect on a lot of folk, longer waiting lists, and it's also discouraged people from going into hospital and having their coronary arteries reamed out in the cath labs and all that kind of thing, which is, mortality has gone up, and it's not entirely a mortality due to COVID-19. It's gone up because other effects of the reaction we've made to the virus are having this bad effect on overall health. And I think it's a phenomenon that the epidemiologists called harvesting, where in an outbreak you get the people who have perished as a consequence of the infection, and you get other people whose mortality has been due to related but not directly to the infection itself. And I think that's being shown in the mortality figures at the moment. So the sooner we get rid of the virus, the sooner we'll be able to get rid of all those side effects, and the sooner we'll be able to pay attention to all the mental health issues that are surrounding it, as well as the other effects, some of which are lethal. So, it really does come back to the only way we can sort that out is to sort out the bloody virus, get rid of it.
Thank you very much. David Thomas.
Thank you, Convener. And good morning, Professor. Professor, where are the gaps in evidence that is needed to inform the exit strategy from this pandemic?
Professor Pennington.
That's an intriguing question, because for many of the aspects of the lockdown, we don't really have evidence that they work. It's not to say they don't work, but an example that one could quote, for example, would be the Cheltenham Festival. There was a lot of jumping up and down that it was allowed to take place. But what we haven't seen yet is how many cases, how many people contracted an infection because they were at the Cheltenham Festival. And, traditional shoe leather epidemiology, as I called it, would have sorted that out by now. There would have been a study done asking people who'd been there, did you have an infection, how many cases, and so on. And it's the same with the Liverpool Atletico Madrid football match as well, which again, people in Liverpool have been jumping up and down about. And it's very difficult without doing some straightforward epidemiological work. And the same applies to closing things down. It's common sense that pubs are a good place to catch a respiratory infection because you're in there perhaps for an hour or two, you're close to strangers, there's a lot of heavy breathing going on. The atmosphere is probably conducive to the survival of viruses because it's humid and warm. And you know, but at the end of the day, of course, what science is about is challenging common sense. But nevertheless, I think that's an area where we probably find that the science and the common sense came together. It's less certain in other areas, and the big area of uncertainty, which is a big problem, are schools. And I go back to the idea that the pandemic planning has always been based on influenza up until this pandemic, and we know that schools are incubators of influenza, and that's why we're immunizing children, so to stop them being basically the incubators of the virus. They go to school, they spread the virus, they don't suffer terribly from the virus, but they take it home, and grandma and granddad sitting by the fire are infected by them going to see them. And that's a very well understood, and there's good evidence that schools are really very powerful. The last big pandemic we had in the UK of a similar mortality, not a bit less than this one, happened in 1957-58, the Asian flu pandemic, which killed 20,000 people in the UK. And we know that that virus came here in the summer, and it lurked until the schools opened, and then it took off in its first wave, and then the second wave came after Christmas. And that's the sort of model that we're still using. But schools, the evidence that COVID-19 is busy in schools is not there. In fact, there's evidence against it. There's a very nice study done in Iceland, and they didn't find any virus in children under 9, but they found lots of virus in other people, particularly people in Iceland who'd come back from the UK before we knew we had a busy virus, but they'd also had people coming back from Italy and so on as well. So, the evidence for schools, that's a stinker for policymakers, because do they take the risk and open the schools? Do they take and open the schools with social distancing, which is going to be very difficult? Or do they just say, let's be on the safe side? I'm just glad I'm not a policymaker in that one, because that's a very, very difficult one.
Thank you very much. David Torrance.
Thank you again, Convener. Professor, finally, what lessons can be learned from the outbreak that could be applied to any future COVID outbreaks?
Professor Pennington.
Well, I hope we don't have any more COVID-19 outbreaks. My hope, if we get all the control measures right and we get the contact tracing rolling on a massive scale, that we will be able to see the virus off, and being sort of optimistic. I think setting ourselves a target of just before Christmas would be a good one. We might not make it. The virus might take us by surprise because we're in the hands of the virus after all. But the lesson that we have to learn is that we have to do better on our pandemic planning. We do have to have better stocks of PPE, for example. We do have to have really good testing facilities. They're not necessarily running, but they're to cope with a surge capacity. And that is going to be difficult for governments, because governments don't like to spend money for something that ain't going to happen. Reasonable. They want to satisfy the taxpayer that their money is being spent on something that, affects them positively as taxpayers. And, I'm fond of making a quote about the civil service is a very conservative with a small c body, because it's always looking for, efficiency and economy and all that kind of thing. And there's nothing wrong with that. But on the other hand, you have to have this surge capacity built into your systems. And it's like insurance that, there's no point in saying, which I think may have happened, as I alluded to a bit earlier, that because the last pandemic turned out to be a pretty well, trivial non-starter pandemic, and the previous ones haven't been all that bad either, that means that the future ones are going to be the same. Absolutely no guarantee of that. All we know is there will be other pandemics. We don't know when they will happen. We don't know how serious they'll be. But if we're not prepared for them, and we're not spending that bit of money, it's not vast sums of money, having that capacity to cope with them, well, we would have the same issues that we've got now with COVID-19. Whether we'll have another coronavirus pandemic, it's possible, because coronaviruses are busy. We've got 7 running at the moment, 7 coronaviruses. But my optimism, if I could conclude this this part of my evidence, my optimism rests on what happened with SARS. That SARS had, when it was busy, it had the same R number as COVID-19, 2.7, and because we put in strict control measures, we managed to eradicate it. SARS disappeared in 2003 and has not come back. And I see no reason why we couldn't be aiming to do that with COVID-19, and aiming to do that as soon as possible. We have to aim to do it as soon as possible so that we mitigate some of the frightful economic consequences and the frightful health consequences, never mind the virus itself, but all the associated health consequences with the virus. So we've really got to be absolutely punctilious about it.
Thank you very much. And George Adam.
Thank you, Convener, and good morning, Professor Pennington. I would like to go through some of the things you've already said today, because some of them go against most of the popular advice we've all been given. The first one was you believe that we shouldn't be looking to level or flatten the curve, we should be looking to eradicate the virus. And you also say you have the doubts about the vaccine and that there's no evidence that there's going to be a second peak of the virus. Now, I know you've said much of it is speculation in what you've said, and I know there is a need in times like this for academic debate on these matters, but I'm coming from the perspective of some of my constituents who will be sitting there worrying about this virus in their homes at the moment. They'll be worrying how they go forward. And when they hear someone with your expertise say things that are contrary to this, why should they listen to you? And what evidence do you have to back up much of what you said, or is it your own opinion on the current situation, given your expertise?
Professor Pennington.
Well, clearly it's my opinion based on my knowledge and expertise, and I've been a virologist for many years, and I've seen things come and go, and I've been involved in flu pandemics, and I did my original PhD work on flu viruses and other viruses to find out why they were so nasty. So I would quote that as an example of where I'm coming from. But at the end of the day, you're right that an expert is just an expert, and I'm just one voice among many. But clearly, my evidence is not based purely on supposition and guess. It is based on evidence, mostly on other viruses, but also on the enormous amount of literature that's already come out on COVID-19. And we say, oh, it's a virus about which we know very little. Well, that's true, but we're beginning to learn an enormous amount. Every day, scientific papers are coming out, and all the big journals like Nature and Science and New England Journal of Medicine and Lancet, they've made their content on COVID-19 free. Not in their business interest, but they've made it free so that we can see these papers almost instantly. Now, a lot of the data that's coming out has not been peer reviewed, so it has to be taken with caution on that basis. But my guess about a second wave is that it's got in there because it was in the pandemic plan, which was based on influenza. And we haven't had a second wave in countries that have managed to control the virus. So why should we have one? For example, this is not influenza. It's very different from influenza, and there's no reason to suppose it's going to behave like influenza. In fact, in many ways, it hasn't behaved like influenza. The age range of people who are infected by it is quite different. Its pathology is quite different insofar as we can judge from influenza. And the only real similarity is that it spreads on the air just like influenza does, but this virus gets around much more easily because a lot of the virus spread has been asymptomatic individuals, and that's based on research. So a lot of my guesses are not pure guesses, they're observations and opinions based on scientific research that's being published. Some of it has been peer reviewed, some of it hasn't. So it has to be taken cautiously. And on some of the things, I may be wrong. There may be a second wave, but I think it's very unlikely that there will be a second wave. And basically, if we keep the control measures up at the moment, and all the evidence that's there suggests that the virus numbers of new cases, for example, is coming down. The deaths, however sad they are more difficult to interpret because it takes between 3 and 4 weeks between somebody actually being exposed to the virus and then going to hospital and then having an unhappy outcome. So the deaths are very much in arrears of what's actually happening. Even the new cases are about a week in arrears because the incubation period of the virus is about 5-6 days. So basically, the figures that we have, the best figures we have of new cases, confirmed cases, I put a lot of weight on that as a microbiologist because the confirmed cases, one where you know the virus was there. A suspected, a suspicious, a possible case is no more than that. And, in the court of law, it probably wouldn't carry very much weight. Well, it might in a civil case, but it certainly wouldn't in a criminal case, for example. And that's the sort of level of evidence we want. We want really good, solid evidence that what we're looking at is actually what's happening on the ground, even if it's only a partial measure, because we know there are many cases out there. So that's where I'm coming from in terms of the evidence that I've been using to support my arguments here. And I would hope that you would agree that basically what I'm saying is it's a reasonably optimistic position in that there's no reason, in my view, why we shouldn't look at SARS as a model, a virus that we managed to control and eradicate, unlike flu, which is a virus that we've never managed to eradicate and which lives with us every year and kills people every year, particularly in care homes and so on. I don't see any reason why we should be so pessimistic as to follow the flu model when we know that this virus is very different. So that's the philosophy underlying my view.
Thank you very much. Georgia.
Thank you, Professor Pennington. Well, you'll understand my own views coming from the point of view I'm caring about my constituents and how they're going to deal with this on a day-to-day basis and how they have to listen to the various ideas that have been put out today. But one of the things that you mentioned was the fact that testing. You mentioned testing earlier on. Now, I might be totally wrong here, so just correct me if I'm wrong, Professor Pennington. Basically, I'm asking, are you saying that everyone should be tested? Like if I get tested today, I may come in here next Tuesday into the Parliament and I may be okay today and have it next week, but I've already been tested. Would we have constant cycle of testing? How would we actually do that testing? Is that what you were saying, that everyone should be tested?
Professor Pennington.
No, I wasn't really saying everybody should be tested. I'm saying that we should be using it as a contact tracing method, which means that you find somebody who's got the virus. It may well be that they have symptoms and they're tested and they test positive, and then you track who they've been in contact with in the previous week, and you may well want to get in contact with the people who were in contact with them the week before. We know that the virus can be excreted by people for longer than a few days. It sometimes is as long as 2 or 3 weeks. And so testing all those people in that chain of contact will help you to focus on, help you to find where that person, the initial person, got the virus, and then the contacts, if they're positive, basically they have to, self-isolate, and the contacts of the contacts have to self-isolate. So you're putting a heavy burden on them, but no heavier than you would be putting on anybody who tested positive who had the symptoms anyway. And I think most people would agree that if that happens, those people who are tested positive by being found by contact tracing, would probably be quite happy to be told that, because they would know that in a fairly short order, they would become negative again. But clearly you'd have to do that as well before you let people out the ideal thing is to test people to make sure that they've gone negative. And I think this has been a bit of a problem with care homes, that people have been discharged from hospital who had the virus, but they haven't been tested before they go out of the hospital to show that they've got rid of the virus, that they're negative. So it's a more focused pattern of testing that we would be employing, and it would be hunting for the virus among the population of people, many of whom will have very mild or even no symptoms at all, but are still infected and are still infectious, and finding them, getting them to self-isolate for a while and stop the chain of transmission. And if we can do that effectively, and as I said, we have to wait till the number of actual cases at the moment has come way down before we can start doing that with a reasonable chance of success. If we can do that, we can do what we did with SARS, and we've only managed to eradicate one virus so far in the world. SARS, two actually. SARS, we've done it, and we did it with smallpox, and smallpox had an R number of 5. So, we managed to do it with a virus, but smallpox was a special case because clearly people had spots, so they were easy to spot, except that we often got the diagnosis wrong and thought they had something else instead. That's a separate issue, but as an example of how it can be done, I think there are examples to follow where we had success, and clearly time will have to go by before we can move aggressively into that mode. How long it will be, I just don't know, because we're in the hands of the virus. And what we have to make sure is that the number of cases have actually come down very substantially. And I was quoting a figure of tenfold before we get to that point. And then we can really go for the virus, in hunting mode, as it were. It will take a lot of effort. And if I could just throw in one particular thing, I know environmental health officers very well in Scotland. I've had many dealings with them over the years, a very excellent professional body of folk. There must be a lot of them twiddling their thumbs at the moment because they spend a lot of time inspecting restaurants, which are all closed. They're very good at interacting with the public and asking questions and having that doubt in their mind, is this person telling me exactly what, the truth, let's put it like that. And they would be brilliant at training contact tracers and doing it some themselves. But we have that corpus of people in Scotland, highly professional people, probably underemployed at the moment for no bad reason, for good reason, but a reason nothing to do with them, but to do with their employment. So I think technically we can do it. Let's get on with it.
Thank you very much, Professor Pennington. Unfortunately, time does not allow us to take any of the several supplementary questions that I know colleagues would like to ask. But can I simply ask you as a last question, Professor Pennington, if there was a single point that you thought this committee should make to those responsible for policy, particularly looking ahead as to how we might move forward from lockdown, what would that single point be? Professor Pennington.
I'll just quote the Director General of the World Health Organization. I hold the organization in high regard, despite what other folk have said. Test, test, test. If we can get that message and get that testing really blasting away, get those facilities that are there in research units working night and day, we can sort this problem.
Thank you very much, Professor Pennington, and thank you very much for your very comprehensive answers to a wide range of questions this morning. It's much appreciated, and that brings us towards the end of the public part of this morning's meeting. Our next meeting is provisionally scheduled for next Tuesday, the 5th of May, which will be notified in the usual way in the Parliament's Business Bulletin and via the committee's social media. We will now suspend briefly for 5 minutes and then move the committee meeting into private session. Thank you very much.